You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is part 2 in a 3-part series on clinical reasoning. In part 1, we take a deeper dive into the mechanistic deductive reasoning. Here, in part 2, we'll contrast that with inductive reasoning. Next, in part 3, we'll bring us all together with how and when we can use deductive, inductive, and abductive reasoning strategies to take the best possible care of our patients. All right, just as a refresher, deductive reasoning is a steady, methodical, and often exhaustive method where we go from a general hypothesis to a specific conclusion. We gather more data, we make more observations, we do more testing, and finally we come to some definitive diagnosis. This may include a long differential diagnosis. Could it be X, Y, or Z? And we go from general theories to a concrete explanation and conclusion. As we've mentioned, deductive reasoning is probably best used for the stable but concerning patient. The headache for 3 months. The abdominal pain that we're unsure of but we're concerned with. General to specific, looking for a definitive answer. That is deductive reasoning in a nutshell. Sometimes that just won't do. What do we do for the critical patient? Or the patient in extremis? Or what do we do with the relatively stable patient with a high-risk complaint or presentation? Practically speaking, when we don't have the time or the resources to spend on a painstaking, exhaustive workup, we have to find another way. Chest pain, sure, it could be costochondritis or precordial catch syndrome or some musculoskeletal thing or a long list of things. That mode, deductive, working painstakingly through a long list of general theories, it may be fine in other settings, but it's a hook with some bait on it, with a hope that the diagnostic fishy will eventually come and chomp on it. A high-risk complaint like chest pain requires not a hook, but a harpoon of action. In high-risk situations, we need to take aim on that big white whale of a dangerous possibility and take him down. Inductive reasoning is what I'm talking about here. With inductive reasoning, we go from the specific observation or complaint or finding, basically what the patient comes in with, and we go to the global theory that could be explaining the presentation. Inductive reasoning, you see, is the opposite of deductive reasoning. Deductive goes from general theories to observation. Inductive reasoning goes from the observation to a general theory. Let's take the common presentation of, say, an 8-year-old with headache. Maybe he's had it before, maybe he hasn't, maybe it's been constant for 3 months, or maybe it's recurrent for 3 months. You've seen this presentation many times before. Deductive reasoning says, hey, I'm really smart. I have a pre-programmed list of 1,000 things that could cause headache. I did a history, and now I think it might be one of 100 things. I did a physical exam, and now it's more likely that the headache could be one of 5 things. I need more and more data, more time, more tests, more exams to deduce in an iterative, stepwise fashion what the specific diagnosis will be. Inductive reasoning says, look, that's pretty cool, but there are certain things, certain diagnoses that I own. I need to think about those things regardless of how likely they are. Inductive reasoning says, Cool differential, bro, but I need to know now whether this headache is subarachnoid hemorrhage, meningitis, trauma, bleed, or tumor. Now, how likely are any of those things? On a population level, not likely. On a time-sensitive contextual level, we got to find out. Now, finding out may be just a thought experiment. You don't need to CT and LP everyone who comes through with a headache, but you do need to check yourself each time. What are the diagnoses I own? When you send a patient to a cardiologist with chest pain, he's not going to check whether the patient has malaria, porphyria, reactive airway disease, anxiety, or depression causing the chest pain. He or she will look into cardiac causes of chest pain and report back what he or she thinks. This is inductive reasoning. She owns these. She looks into these even though the likelihood of a cardiac cause may be low. This is one of the reasons that you're not going to leave a cardiologist's office without an EKG done. We need cardiologists to do what they do. The cardiologist is a specialist charged with certain diagnoses. But guess what? So are you. This paradigm of context can get messier when we speak about emergency medicine because we see anyone, anything, anytime. Messier, or I like to think, more awesome. As emergency physicians, we are both specialists and generalists simultaneously. We're generalists in that we see anyone, anything, anytime, but we're specialists in what we're charged with, what society asks of us. We need to think about and address life-threatening causes of a presentation, and that may be all that we can do in that particular case. So, we have to be comfortable toggling between seeing anything and finding something. This gets even muddier when patients who ideally should present to another setting come to us in the ED. Each setting has its own intrinsic bias because of context. In clinic, an internist, a pediatrician, or a family physician will be biased towards wellness because, frankly, if you're well enough to show up to clinic, you should be well enough not to have something terribly wrong with you acutely. Presumably, if you need to come to the emergency department, oh wow, you must be doing poorly. Now, we know that that's just not the case in many, many people that we see, but we do know that if the clinic's prescription of tincture of time doesn't quite work, the safety mechanism is us in the ED. For us, there is no further safety net. Even though we know that we see a mixed bag of truly sick and those who seem to wander accidentally into the department, because of our context, we're biased towards disaster. This fundamental philosophy, this extra strand of DNA that we have, gives us our superpowers of keeping our patients safe, but it also makes us almost completely incomprehensible to the rest of the house of medicine. No one gets what we do or why we need to toggle between deductive and inductive reasoning. So, to paraphrase Mark Twain, always do right by your patient. This will gratify some people and astonish the rest. Inductive reasoning, as we've talked about, is best for high-risk presentations or complaints. Susie is 8 years old and complains of a severe headache that is worst on onset. Deductive reasoning will generate a pre-programmed list of headache causes, and the search engine bot in your mind will need more and more data, and then may or may not get to the right answer in time. Inductive reasoning will say, cool, it was probably the ice cream she just gobbled down, but what I hear is a thunderclap headache, and what I see is an uncomfortable girl. What I need to think about or even investigate right now is whether or not this is a subarachnoid hemorrhage. You may have heard just enough to CT and LP, and that's okay. If she meets the threshold to investigate a diagnosis that you own, then own it. It's okay if you're not convinced that it's a subarachnoid hemorrhage. If you think there is enough based on the history and physical to meet that threshold for your investigation, then you're obligated to investigate. More importantly to all of this, you're obligated to address the life threat, not necessarily every diagnosis. Now, addressing it may just mean a good H&P, but it's perfectly fine to hold two conflicting ideas in your head at the same time. I don't think it's a bleed, but there's enough to look into it, and that's what I'm here for. Society needs us to be that way. After your good H&P, you may just see that she has a normal neuro exam. Susie is comfortable after an NSAID. Her serial exams are normal. She has no known risk factors for an aneurysm. And yes, you have collateral information that all was well until she gobbled down the ice cream cone, and now her chief complaint is terminal boredom. Did you feel that? Did you just get a little twinge of uncertainty? What really is to say that she doesn't have both? Now, I don't want to paint a picture that clinical decision-making is as simple as choose your method, deductive for stable, low risk, and inductive for unstable, high risk. Most of the time, we live in uncertainty, and we just have to be comfortable with that. Before you throw your hands up in defeat, I have something to tell you. We do have a great responsibility. But with that great responsibility comes a great power. That power is our abductive reasoning. Abductive reasoning is the process of gathering an incomplete list of observations and going for our best educated determination, otherwise known as our best guess. More on abductive reasoning in the next episode. Just to recap, deductive reasoning in the clinical arena is going from a huge, long, ginormous pre-programmed list of diagnoses, gathering more info and refining that list. It's all about the list, and that usually takes time. Inductive reasoning is saying, hey, you came to me to make sure you're not dying. These are the things that can kill you or maim you. You have or don't have them. You're welcome. You can see that this is a very efficient way to keep people safe, but it can be a very unsatisfying way for you and for the patient. It's best used for high-risk complaints or patients. Abductive reasoning is where the magic that is within you happens. Magic that you'll learn in the next part of this 3-part series, but until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@PEMplaybook.org or drop by our website for show notes and more strategy at PEMplaybook.org. See you there.